afternoon. Good afternoon. We're super excited today to have Dr. Young Lee join us. And Dr. Lee and I have worked together for, 15 plus, almost 20 years, since back when I was in Redmond and he was at Sport and Spine, split between a couple locations there. And now, he's the head guru here at Physical Medicine and Rehabilitation at Evergreen, as well as continuing to do some lecturing and teaching at the University of Washington. I think one of the things that's been great working with Dr. Lee for all these years is just your attention to detail, whether it be diagnostics or patient complaints, as well as just the time you take to listen. So this isn't meant to be an infomercial for Dr. Lee, but I would say, we only invite the physicians that we really like on here, for one, but I think we've never had a patient come back and have a disappointing experience. They can be disappointed in their own body, but their experience with Dr. Lee and the rest of the team at Evergreen Sport and Spine Care has been outstanding. So it's always fun I know there's a lot of therapists that will be on this. It's always a really great, safe referral where you're going to have a good experience for your patients. And I know so many of our therapists really cherish that relationship with the patient. So it's really a safe referral too. So if you have questions, we'll have some information in the show notes, which will be available afterwards, as well as on the YouTube channel that will have ways to contact Dr. Lee and his team. And again, just a kind of quick housekeeping thing. If you have questions you want to get across to us today, there is a Q&A tab. You can send a message to us and I will bring those up at the end of the lecture here. And we do have some questions that people send in ahead of time too. So we'll get through those that people have messaged me through Facebook and direct messaging and make sure those are all taken care of as best we can. But without further ado, we really thank you for your time. I know it's a beautiful day here in Seattle and taking some time out of the sunshine to join us here. So appreciate it. I'll let you take it from here.
Thank you, Ben. And I really thank you for inviting me to give this talk. And thank you, all of you who are attending this webinar. And I also want to thank the people from Relievant who's allowing me to use some of the slides today. So I'm going to be talking about chronic low back pain, and whether you're a practitioner, physician who treats low back pain, hopefully you can identify the issues that occur with low back pain, and hopefully this gives you some insight into potential treatment that we could be providing for people with low back pain. So the title of my talk is Treatment of Chronic Vertebrogenic Low Back Pain. So I don't have any financial disclosures that's going to affect this talk, so I don't have any of that. But there are some important disclosures that I want to make, and I think if my wife had it her way, that she would say, please don't disclose any of this stuff. But through the pandemic, I realized my health is very important, and so I looked at my health and I said, what changes could I make? And one first disclosure is that I'm a big proponent of the plant-based diet. All the studies show that it improves your biomarkers, it makes you feel better, potentially you could even gain more muscle, reduce the risk of obesity and diabetes. And so, I'm a big proponent. And so if you haven't tried it, I would highly recommend it. I do have a second disclosure, is that I'm also a big proponent of the animal-based diet. Just because steak and bacon are delicious. Third disclosure is that I kind of went to my roots. I'm a big sports guy. I'm not really good at any sports, but in this sport, I kind of lettered in it in junior and probably senior year, and so I'm kind of proud of it. So I kind of came to my roots, and I've been playing a lot of this sport lately, and so my favorite sport is karaoke. Just to let you know, just to get. So you could kind of get to know me. Enough of that. So what are the goals of today's talk? One, understand vertebrogenic low back pain. So what is vertebrogenic low back pain? I'm sure you've heard lots of discogenic back pain or SI joint pain, facet pain, but this is a relatively new term. So we're going to try to understand what vertebrogenic low back pain is. We're going to learn how to diagnose vertebrogenic low back pain. And I'm going to describe to you some indications and treatment outcomes of the treatment for vertebrogenic low back pain, which is the basivertebral nerve ablation, or also known as the Intercept procedure. As you know, a lot of you guys know low back pain is a very significant problem for us. 80% of individuals experience significant episode of low back pain at some point in their life. Not surprising. Now, when I was in residency and graduating our residency, we were always taught, you know what, vast majority of people, their low back pain gets better very quickly, potentially up to 50% get better within 2 to 4 weeks, even if we did nothing. And then there was even a quote of potentially 80, 90% in 2 to 3 months, if we did nothing, potentially could get better. And so that's what initially what our thoughts were. But if you really look at the prevalent studies of low back pain, we're finding out that may not be the case, which probably is not a surprise to many of you who treat low back pain, because you see these patients coming in over and over again. And 66 to 75% still could have mild pain even 1 month after seeking care. 20 to 25% report substantial activity limitations even 1 year after their diagnosis, and 15% could still have back pain that's in the severe intensity category, which is a significant portion of the population. Not only is it painful, but it's very costly. It is one of the most common causes of disability in the United States. An estimated 149 million days of work per year lost due to low back pain. And there's potentially annual cost of $100 to $200 billion per year because of low back pain. Now, large majority of this costs are incurred by a small subset of low back pain populations. And there could be a reason why, and we're going to talk about that. So unfortunately, it appears that majority of patients with chronic low back pain don't get adequate pain relief. So they go into this vicious cycle, as you can see. They might start off with some medications, whether it be non-steroidals or opioids, and then it doesn't get better. And they might try some neuropathic pain agents or adjuvant pain medications such as gabapentin, Lyrica, Cymbalta. They may try physical therapy, maybe several courses of physical therapy, or then go to see a chiropractor for some chiropractic adjustment treatments. And they may come see one of us, a physiatrist or anesthesia pain management specialist, to get injections. But as it doesn't work, they may try the TENS unit, a structured pain rehabilitation program, which may include occupational therapists, psychologists. They may try all sorts of things, but they may try them over and over and over again. I'm sure you have seen these patients, or you may be one of those patients, unfortunately. And if you look at the numbers, it's potentially 74% of patients may have unresolved pain even 2 years out. That is a huge number of people. And hence, it doesn't appear that if we did nothing, that patients, 80, 90% get better within 2 to 3 months. So I want to present to you a familiar low back pain case. I'm sure if you treat low back pain, this may be a patient that comes into your clinic, or you may be this patient. And so let's say a 48-year-old male who's a weekend warrior, who's a manager at a local tech firm with chronic intermittent low back pain. He describes that his first episode of back pain was in his late 30s after falling while snowboarding, which improved after a few weeks of rest at that time. Since that time, he would have intermittent flare-ups, or it would be kind of where his back would, quote unquote, go out on him, until the last 8 months, it became much more severe and the duration, and it has not been relieved. He describes that there's been recent changes, psychosocial changes, perhaps, as we would say it, maybe working from home. He described inadequate workspace because he's working from home. Because the kids, if you have kids just like me, you know this, is that kids are home, remote learning, and he's got increased responsibility. And that is causing increased stress in his life. And also with the political unrest, he's not getting good sleep. He tries to exercise because he was told that exercise should help with back pain. He even purchased a Peloton and has been using it regularly when he's not in severe pain. He's been to the ER twice, tried 2 courses of oral steroids. He's tried not only one, but he's tried a second physical therapist, hoping that he would feel better. And they treated him for his pelvic obliquity, weak core muscles, tight hamstring, his hip flexors, but they continued to have back pain. He saw a chiropractor, and he was told that it was his SI joint, had his SI joint manipulated, he had his leg length corrected, persists to have back pain. Was frustrated, went to see an acupuncturist. They diagnosed him with low kidney energy and corrected his meridians with acupuncture treatments, but unfortunately his pain persisted. And he saw a naturopathic physician looking for help anywhere he could get it. He was diagnosed with food intolerances. He tried a low inflammatory diet and tried some herbal supplements, but his pain continued. Eventually, his primary care doctor referred him to see a spine surgeon. He walked in and the spine surgeon looked at him and said, I don't know why you're here. Your MRI doesn't look that bad for surgery. There's not much we could do for you. You know what? You need to go next door or down the street to see these guys at the physiatry clinic. They may be able to help you. They go see a physiatrist like me. They tried epidural steroid injections, sacroiliac joint injections, facet joint blocks without long-term improvement. At the end, the physiatrist talks to him about trying cognitive behavioral therapy and trying mindfulness, as that is shown to show improvement of back pain. He's tried a variety of different medications of all type, as I described before, and is online looking for treatment. He's thinking about getting stem cell injections or finding a surgeon who would provide him with fusion surgery. He's hopeless. He's dejected. He's fearful. Now what? Are there any other treatments for this patient? So first of all, before we get into vertebrogenic low back pain, I want to talk to you about what we traditionally knew as potential sources of low back pain. And this is something that we don't oftentimes think about or even talk about. For instance, when somebody has knee arthritis, what is the source of that pain? Because as we know, imaging doesn't always correlate with how much pain someone is having. Same with the rotator cuff tear. If 60 to 70% of patients after the age of 70 have asymptomatic rotator cuff tears, do rotator cuffs really hurt? So we don't really talk about it. We just kind of treat it, think it is the tear, but we don't know exactly what it is. Well, if you're an astute spinal diagnostician and perform injections, we have some idea that based upon the studies, what could be the source of low back pain. It really came down to three structures. And if you look at this slide, it's commonly quoted that lumbar intervertebral disc or discogenic pain or internal disc disruption is known to be the source of between 30 to 50% of low back pain. The sacroiliac joint, possibly 20 to 30%, 20% if you've never had fusion, maybe 30 to 40% if you had a lumbar fusion surgery. And the lumbar zygapophyseal joint, also commonly known as a facet joint, possibly less than 10% if you're younger. And as you get older, as the stress goes from your disc to the posterior aspect of your spine, as shown in this diagram, that the prevalence goes up to possibly 40%. And the diagnosis is usually made through injections. Unfortunately, we found that physical exam maneuvers are not very helpful to make the diagnosis. We get some ideas based upon some exam maneuver findings, specifically for SI and facet, but it's really hard on exam and history alone to make the diagnosis. So for discogenic pain, provocation discography is a procedure that is performed to basically to irritate a disc to see if someone essentially screams and they're in pain, and compare it to a adjacent level disc to see if it causes the same pain. If it doesn't, we know that the painful disc is the source of his pain. But it is not commonly performed, especially in this area, because unfortunately we found that there really isn't a definitive treatment for discogenic pain. And if you treat discogenic pain in the past, you may have heard of the IDET or biocoplasty, but which is basically deadening the nerve zone around where the disc is innervated. But we found out there's not a valid treatment for discogenic pain. For facet pain, if you block the nerves that innervate those joints by anesthetic, we could diagnose that they could have facet pain. And for sacroiliac joint, you could have an intra-articular source of pain, which is injecting deep inside the joint itself to numb it up to see if they get pain relief. That's how we know if someone has SI joint pain. Or lateral branch blocks, which is what we call the extra-articular source of SI joint pain, which is the ligaments and et cetera. And so these nerve blocks and joint injections can be helpful. And if you look at the numbers again, to understand how much of your back pain could be coming from a deep internal source of pain. But because we don't commonly perform discograms, and if you look at the prevalence, potentially we're only finding the source of people's pain possibly up to only 50%, possibly, if we're doing great. But up to 50 to 85%, we diagnose them as non-specific low back pain. We really don't know where the back pain is coming from, which is a huge challenge. If you don't know what you're treating, how can we treat it, right? So now I'm going to talk to you about vertebrogenic pain. Now, this is a relatively new term. As we talked about, we talk a lot about this. We're finding out that understanding about vertebrogenic pain is a paradigm shift in the science of low back pain. While the disc, again, has been historically been accepted as a common source of low back pain, research confirms that the vertebral end plates, and if you look at the diagram, here's a picture of a disc with the vertebrae up top, vertebrae below, and the disc in between. The end plate is the interface between the disc and the vertebrae. So we found out that these end plates, as they become injured through degeneration or trauma, that inflammation could get set in, and this chronic inflammation could lead to what's called modic changes, coined by Dr. Michael Modic in the 80s. And we're finding out these vertebral end plate damage or injuries can be a distinctive source of low back pain. And these end plates we're finding out are more innervated than the intervertebral discs, which are surprising because we always were understood that the sinovertebral nerve innervates the posterior aspect of the disc. Hence, if you develop a disc tear or herniation, or even with this relatively looking more normal, if that sinovertebral nerve becomes activated, that someone could have discogenic pain. We're finding out that these end plates are actually more innervated. And the basivertebral nerve, which is a branch of the sinovertebral nerve, innervates these end plates and can be damaged. Damaged end plates could send pain signals by the basivertebral nerve. And these modic changes, as I will show you on the next slide, are associated strongly with chronic low back pain. So if you look at the data of looking at specificity of these findings, and here's a MRI images on the right. First is what's called a T1 weighted image of the MRI, and on the right is a T2 weighted image. And T1 weighted images, the fat appears bright. On the T2 weighted images on the right, this fluid appears bright. And if there's brightness, it's fairly simple. If you look at the brightness here and brightness here, those are called modic changes. And if you find these on MRI, we found out potentially between 90 to 100% specific in being associated with low back pain. And so if you find this, vast majority of these patients will have low back pain. And these changes were associated with historically with low back pain. And we found out that they could have more severe and longer duration of symptoms if they have modic changes. And unfortunately, when they have type 1 modic changes, which is brightness on the T2 weighted signal, which is kind of what I explain to patients as swelling around the disc into the bone, that patients have poor outcomes. And this is not surprising. And anybody who treats knees, we treat a lot of knees also. People with arthritis, if they have these subchondral edema or swelling underneath the bone, those same patients in the knee also have very poor outcomes with conservative treatments. And so if somebody has, let's say, edema, subchondral edema within the femur, and they have a meniscus tear, even if you partially treat the meniscus, they may persist to have pain because of the pain coming from subchondral bone. And this is kind of the same idea that's happening in low back pain at this point. So when should you suspect somebody has vertebrogenic low back pain? Well, if they have chronic episodes of back pain with varying degrees of duration, sometimes it's better in a few weeks, sometimes it's better in a month, but they continue to have these episodes. They don't respond to conservative treatments very well. All the treatments and you know that we could provide, therapy, chiropractic, injections, medications, they don't respond very well. They tried multiple different injections with varying relief. Sometimes one works, sometimes it doesn't. The second time you receive the injection, it might not work at all. Generally, exams shouldn't show any new neurological deficit if you're suspecting, for instance, if they suddenly have a foot drop, I'm not thinking they have vertebrogenic low back pain. And generally, they shouldn't have any red flags, such as fever, chills, night sweats, trauma, fracture, cancer history, or back stiffness greater than an hour. That's more associated with inflammatory causes of arthropathy, such as ankylosing spondylitis. So I have a pop quiz first. So if you suspect someone has vertebrogenic low back pain, what tests should be ordered? Is it a urine drug screen? COVID-19 antibody? An X-ray perhaps? Or an MRI? Yes, D, MRI. And if someone can't get an MRI, you can get a CT scan or what a bone scan, SPECT scan fusion with the CT scan to show end-plate edema or sclerosis. Now I'm going to talk to you about the treatment for vertebrogenic low back pain. Intracept is a minimally invasive procedure that targets that nerve, the basivertebral nerve, for relief of chronic low back pain. There's some key benefits for this procedure. This is good for patients who have not responded to conservative treatment. So I would still recommend those patients, even if you suspect that they have vertebrogenic low back pain, to try all those other treatments. It's minimally invasive. It's an outpatient procedure, so you're not admitted to the hospital for days afterwards, and recovery is very quick. It's implant-free and preserves all the future treatment options. So because there's no metal getting implanted, it's not like you can't get MRIs in the future, you shouldn't get surgeries, nothing like that. It preserves all future treatments. And it provides durable relief of vertebrogenic low back pain. Now I know what you're thinking, prove it, right? Well, first I'm going to describe to you how the procedure is done. So here's a diagram of how the procedure is done. First, here's a diagram of a vertebrae and the bone, and the center is the basivertebral nerve. And you have this transducer that gets placed through the pedicle, and once the transducer gets docked into the bone, another plastic curved transducer is placed to create a tract that goes down to the basivertebral nerve. Once that tract is created, and we're checking this under X-ray guidance to make sure we're in the right spot. So we're not guessing here. We're hoping to hit the right spot every time if we can. And then a radiofrequency probe is placed, and through the generator, electrical current is created where the nerve gets heated for 85 degrees centigrade, not Fahrenheit, centigrade. So it gets pretty hot. And if you hold that position for 15 minutes, it creates about a centimeter size lesion that basically deadens the nerve. That's how the procedure is done. And as you know, the disc has top and a bottom, the end plate has top and a bottom. So we would do this generally for 2 vertebrae at one level. And if they have several discs that are affected, you could do a procedure at multiple levels. The indications are that someone needs to have back pain for at least 6 months. So it's not somebody that I would say, hey, you got back pain for 2 weeks, let's check an MRI to see if we can do this procedure, right? They need to try conservative treatments as discussed. So Ben, you're gonna have to still work, buddy, sorry. So you're gonna have to see these patients and treat them and try to help them, all right? They need to fail at least 6 months of conservative care. And imaging has to show those modic changes or these end plate changes that are shown on the diagram here. So there's been several randomized controlled trials showing this. So this is not me just believing it by faith, but studies are showing that this could be efficacious and it could be safe. And first is a SMART study. This was and if you look at studies, as you know, that the gold standard is a randomized double-blinded sham-controlled trial. And this is really one of the gold standard studies. It was a multi-center study, 15 sites in the US, 3 sites in Europe. And it was 2-to-1 arm, meaning there was double the amount of people who had a treatment versus who received the sham treatments. And the sham treatment was performed by, they would place a transducer within the bone, but not ablate the nerve. So it felt very much the same for the patient. And they use multiple outcome measures, but the two that are that we use probably the most is the ODI, which is OS3 Disability Index, and the visual analog scale, which is generally between 0 to 10 of how severe their pain level is. And ODI, they're kind of measured, and the numbers are, if it's between 0 to 20, they have minimal disability. If their numbers, it's scored from 0 to 100. And if they're at 100, that means they're pretty much bedbound. And kind of moderate disability is between 20 to 40, and severe disability is between 40 to 60. And when they looked at the outcomes at 3 months and 24 months, patients had 48% decrease in their ODI numbers, which is fairly significant. Now, I know what you're thinking. If you look at this diagram, if you look at the sham study, also the sham people did fairly well also, if you look at the numbers. They started off, both groups, around 40, 41, and 42. But the sham group also got better. Obviously, the treatment group got more improvement. But oftentimes people would look at this and say, hey, look, you can do a fake treatment and some people are getting better. So does that mean that it's effective? Looking at a lot of pain studies, there's, whatever you call it the placebo effect, a non-treatment effect, or what I like to call centrally mediated effect based upon your expectancy. And we're finding out through studies that through dopamine channels and dopamine getting released with expectancy, that some people can get better with the sham treatment. So we understand that. But even if we tweeze it out, we found out that there's more of a clinical significance, which I think says a lot about this procedure, that people are doing better.
I think if I can interject, I think ultimately,
Sure.
too, if you're getting better, I think the patient really doesn't care how they got better.
I completely agree. But and that's the thing is that if we're talking about a fusion surgery, that's another deal, right?
Absolutely.
But if we're talking about gentle treatments that has very low risk, obviously I'm not gonna do treatments that are only shown to show placebo benefits, but you're right. Patients just want to get better, and we're here to help patients, right? So I agree. This second randomized controlled trial called the Intercept study, this wasn't comparing the treatment to a sham treatment. This was against standard of care. And if you look at these numbers of ODI, you can see even a bigger improvement of ODI change at 3 months, with the treatment group having 25 points versus 4.4. And VAS, visual analog scale, reduction of 3.46 in treatment versus treatment by standard of care being only 1. So more significant if you look at it compared to the standard treatment. Now, the SMART trial, they provide us data up to 5 years. I don't know about you guys, but there aren't that many studies looking at up to 5 years, which is kind of bold, because oftentimes with any of the treatments, boy, if I provide a patient with treatment that's lasts for 5 years, people will think I'm God, right? I mean, that is pretty significant. But this treatment has been shown that it's fairly durable. Now, again, if you analyze the data, as expected, it's hard to keep up with all the treatment people up to 5 years. So there's some loss, a drop off for whatever which is described in the study. But if you look at the data, look what happens at the mean ODI over time, between starting at 42.4 up to 5 years. The patients had sustained relief. In fact, it kept on getting better and better. And same with the visual analog scale, from starting around 7 to around 2. And so this is a fairly compelling data showing that patients who got relief are getting continued relief. Now, if you look at the mean data, and means sometimes could look a little bit screwy if you look at research studies, because it could be really skewed by a couple of patients who does horribly in one group and a couple of patients who does really well, and that would skew the mean. And so we really like to see what's called categorical data. What percentage of people got how much relief? And so this is really, really meaningful slide. Mean reduction in VAS was 4.38, and 66% reported at least 50% of relief at 5 years. So almost 2/3. Almost 50% had 75% improved their pain. And this number is just ridiculous. 1/3 of the patients were pain-free at 5 years, which is almost sounds too good to be true. I mean, that is a pretty significant amount of patient population. So at least 66% of getting 50%. I think, that a lot of my patients say, my goodness, doc, if you can get me even 20 to 30% of relief, I would be happy. In fact, if you look at any chronic pain data, if you're reducing people's pain by 30%, you're doing really well. I mean, that is a success by many measures. And so this is a fairly compelling data.
Yeah, I don't want to look like a plant here, but I haven't seen these slides ahead of time, but that's significant data from the standpoint, as well as we're looking at the toughest population of getting people better. So we're not looking at overall back pain. You're looking at the slice of population that is failed everything, and they're still seeing this kind of results is pretty remarkable.
It really is. And this, if you look at the study group, these patients had pain for a lot of them 5-6 years, which is, we're not talking about these patients who's had pain for only for 6 months. We're talking about years of pain that these patients pain was relieved. I have another pop quiz for you. Karaoke in Japanese means love thy voice, empty orchestra, singing without talent, or had too much sake. Ben, since you're the host, I'm going to have you try to guess on this one.
Well, sake makes the most sense from my experience, but I think it'd be singing without talent.
Nice try.
Okay.
Oh, empty orchestra, right?
Go.
Yeah. All right.
Empty talent.
Some more data. Yeah, next time, maybe. Sorry, I don't have a third quiz for you. Another thing is I really like this part of the data. Yes, you could show me the numbers about the means. Fine. Boy, those the numbers about how many patients got complete relief, really impressive. But look at this. The SMART data, they looked at opioid use and spinal injections. When they looked at the data at 12 months, 60% of patient population, the treatment could reduce their opioids. 46% eliminated use altogether. I mean, that is astounding, right? I mean, opioids, it's really hard to get people off of opioids when you start it. And looking at 5 years, compared to baseline, 30% who are using opioids, only 8% were using opioids. And these are numbers of people who are using opioids at least once per week. And out of that 8%, in that 8% group, 4% were using it less than 1 time per week. So even if they're using it, if they had treatment, they were using it much less, which is really good. And to try to keep those numbers down for patients so that they don't develop opioid-induced hyperalgesia and all the side effects and complications opioid we're hearing about because of the opioid epidemic. And if you look at spinal injections, at 5 years, only 4% had spinal injection in the treatment group versus 59% at baseline who received spinal injections. Again, pretty compelling numbers there. And what is the safety profile? Sure, if the procedure works, but if the risk of some of the horrible complications is 50%, I'm not going to be recommending that for my patients. So based upon the clinical trials, there have been 473 clinical trial patients. There has only been 1 serious procedure-related event, which is 0.2%. And it was actually in the sham group. A patient with osteopenia who was being treated with hormone therapy had a vertebral compression fracture, which healed by 8 weeks without sequelae. There have been 25 non-serious device procedure-related events. Most of them, some temporary lumbar radiculitis or lumbar radiculopathy. There was one event of retroperitoneal hemorrhage, which was treated with a transfusion, and one had to be aborted. This was at the S1 level where there was a quite significant dense bone there. And so, yes, there can be some minor side effects, but a vast majority of them were, in fact, all of them were really non-serious and improved over time. So this is good news. That is a treatment that has a very good safety profile based upon all the patients that has been studied so far. So the clinical evidence summary, to bring it down, this is just on the evidence. There's been multiple high-quality studies, including 2 level 1 randomized controlled trials showing long-term clinical evidence. And this is impressive. Again, as Ben stated, this is a challenging patient population. Treatment effect were durable beyond 5 years. And so people who treat lumbar facet pain, like we do, we perform radiofrequency neurotomy. I tell the patient, you know what, even if you get complete pain relief, there's a possibility we may have to repeat in a year because those nerves grow back. Well, with the basal nerve, and because the size of the lesion being so large, we're finding out that it's really difficult for that nerve to sprout because of that, but also because the nerve is really either not myelinated or very thinly myelinated. And so we're finding out that that's possibly the reason why patients have such long duration of relief. Again, 66% reported at least 50% improvement, and third of the patients were pain-free at 5 years. People who received the procedure were utilizing less injections and less opioids, and it has an excellent safety profile. So in conclusion, end-plate edema, or what we call modic changes, is highly associated with low back pain. And the new term is vertebrogenic low back pain. And so again, before it was viscogenic, facet, SI, that's what we talked about. But now we have this new term with the understanding based upon science backing it, that we should be calling it vertebrogenic low back pain. It is pain coming from the vertebra, as we discuss about the knee potentially coming from the subchondral bone. MRIs needed to make the diagnosis. Intercept procedure is an exciting, promising new procedure to treat vertebrogenic low back pain. Thank you. Really, thank you.
Great stuff, as always. I would really concise and well put together presentation. We have some questions. I think first and foremost, in your office currently, you've got a great team. You know, we've worked for years with Dr. Mesley, Dr. Stout, Zender, Kelly Weaver, and Dr. Fry. Like, who is currently doing the procedure?
Currently, it's myself and Dr. Stout, and then more people may be getting trained in the future to do it, but it's myself and Dr. Stout.
And then I've got a couple of questions here ahead of time that we're kind of coming into, and maybe just kind of a little quick background for you. Like, what got you into medicine? What was the key factors there?
Yeah, so when I found out that I couldn't make a living doing karaoke, was first. No, I got into medicine. So I thought about many different things when I was in college. I knew I really liked science, and I really wanted to work with people. So I was a psych major, so it's kind of crazy. And, oh yeah, now it explains it. Now I know it. Yeah, so I was a psych major. So it really came down to getting maybe going to like social psychology or medicine. And I realized I really wanted to be in school for a long time, which I could have done both ways. But I did some research with a physiatrist at University of Washington, which has a great department of physiatry. And he was doing some sports medicine, spinal cord injury, stroke. And I really found that to be fascinating. And so I just went for it. And that's where I'm here today.
You may have answered this next question already, and that was, what's your favorite part of being involved with the University of Washington right now?
Oh, it is working with the residents. Last year I gave them to the residents 3 different talks, and it's not just the medicine part. I think, you know, as if any of you are young in your field, you know, you have a lot of questions, you have a lot of uncertainties, and you learn a lot, but at the same time, you don't know how to navigate all of that. Like, how do you have a family? How do you get better at what you do once you're out in the field, once you get out to work? And so, burnout is a big thing in medicine, and it's so sad to see that there's so much talk about becoming financially independent, retiring early in medicine. Like, you put in all this time and energy to be thinking about retirement. It doesn't, to me, I'm like, that's way too much work. You should have done something else. And so I believe there's a way that you can make your practice fun, enjoyable, that's rewarding. And that's the part I want to kind of teach the young physicians how to get that done. And so, you know, the talks that I gave this year were about how to prevent burnout. How do you negotiate a contract? How to manage finances? And so those things are, you know, really interest me, because I really like to work with young docs and bring them to give them reassurance that things are going to be okay. You're going to like your job.
Yeah, I think that's something for us as well. Like, I think the mentorship component, when you have young clinicians in the office, like currently we've got a couple of DPT students at the clinics, and it reinvigorates the professional side of things and the development, and kind of makes you question where you're at and how everything is kind of going. I think to your other point too, just the rush to retire in any profession is a strange goal, because, you know, you're kind of stepping out of the ability to, at least in some extents, you know, kind of have an impact on people. So I think that's kind of an interesting kind of comment you have there too. I think it's great.
Yes.
I do have one question that just came in from one of the attendees, and that was to not to go deep back into the weeds, but maybe you know off the top of your head. I said, what was the pain-free status of the sham group at 5 years?
Actually, I don't know the data about the 5-year sham. And in fact, I'm not sure if that is on the study from what I read. I would have to look at the details more, but that is a very interesting question. I wonder.
The thing that jumped to mind to me too, like when you were talking about the pain and even possibly having to do the procedure again at a year, it just immediately jumped to my mind is that, the failure of conservative care before this procedure, assuming there's some kind of protocol that you guys like to use post-operatively, you may actually prevent the second occurrence by actually conservative care working the second time, because they've got many of the factors between diet and movement, weight, strength, all these other factors, psychosocial, kind of being able to move again, kind of the dopamine and endorphins kind of being more present in their lifestyle, is that you may actually be able to prevent it just on more of like a post, sounds strange, but a post-operative conservative care being successful. One question I had too was on the osteopenia, osteoporosis type patient. Is that something you guys scan for with the procedure preoperatively, or what are kind of the fail safes?
Yes, and so yes, I would if they don't have the details of that. So for instance, I think if we're looking at any patient, especially if you look at the data on osteoporosis, I mean, it's a lot more prevalent than we know it, because a lot of patients aren't getting their DEXA scan. And so I would definitely find out about their previous fracture history, what they do, are they taking calcium, vitamin D, if they're if they had a DEXA scan. I would look into all of that probably before I would recommend the procedure. Now, the average age of the population that received this procedure was 48. But yes,
super
you
young.
can see this.
Super
yes,
young.
and this is super young, because I am 32. So, and so a lot of young people suffer with this. So that 48-year-old is kind of that typical person that probably suffers a lot with this back pain, who are trying to still stay active, trying to do all these things. He's listening and he's doing all the things that we're telling him to do, but continue to suffer, And so I do see elderly patients with end-plate edema. So it's not that, but definitely the people who probably are really wanting to get this done, and probably the younger patient population.
Well, I think your case study is basically that every patient that we've shared over the years.
Right. Yes.
It was spot on. We actually have quite a few. First of all, I want to give a shout out to Alex Engen, who did get the question correctly, empty orchestra. So nice job.
Oh,
Alex.
Nice work.
That was actually before the bell. So he got it. He got credit for that. Randy, friend of mine here, has a question that says, does sciatic pain come into play at all in any of this?
Yes, it does. So someone, in fact, I have a patient right now. So someone could have sciatica pain along with it. So this one patient has sciatica pain and has actually a new acute disc herniation at where he has the end-plate edema. And if you look at the statistics of how degenerates over time, we understand that yes, even in people without any disc herniations, clearly could develop disc herniation. But if you have an injured disc, that probably increases your probability. So they could have this ongoing intermittent back pain, right? And so the history is, I've had this intermittent back pain. I've been going to the ER for 10 years, and suddenly the back pain is gone. Now I have this rod going down my leg, electricity, right? And it's that disc's been injured over a long period of time. Now the disc ruptures, then your body recognizes the primary source of the pain, which is radicular pain. So if they have sciatica, what I would do is treatment for the sciatica first. And like all my surgical colleagues who say, hey, when you get a microdiscectomy, your leg pain is going to get better. Your back pain may still be there. So I would treat their sciatica pain, do an epidural steroid injection, and get them involved in therapies and chiropractic and treatments. And if they persist to have back pain over time and they have end-plate, that's when this procedure could come into play.
This question is from Eric. It says, I have ongoing back pain issues circling through many PTs, chiros, and got an MRI a year ago. I plan to go back to PT soon. Can the therapists identify if I'm a candidate for this, or should I go straight to the doctor? Been dealing this for 15 plus years.
Well, because you would need an MRI for this. And so it's whoever could order the MRI for you. And not only that, but have to interpret it, because like I said, sometimes the radiologists don't put in play changes. So I spoke to Don Hallstrider, the MSK director of Radia, and I said, please, when you guys read these pictures, please put M-plate edema or motive changes, because for insurance authorization, that's what it takes to show that. And sometimes they don't mention it. They just put degenerative disc disease, which isn't going to get it done. And obviously, if you don't look at the MRI, even if there's degeneration, you really have to look for the M-plate changes, even if there's small, slight M-plate changes.
Yeah, my own little soapbox issue on that too would be that when people are spending the money out of pocket for the deductible for an MRI, is you really want a specialist beyond the radiologist. And I've got friends that are radiologists, I'm not knocking them, but you really want the physician that's seeing the treatment to be able to see the actual films. So I see as many times over the years where someone gets a primary care doc, orders it, the radiologist just sends the report, the physician says, hey, it looks like you're fine. And they show up to PT with a script, and it's like, there's nothing on the report. But then, later, 6 months later, someone ends up in your office or one of the other, great physiatrists in the area. And they're like, oh, this was missed 7 months ago because they never actually looked at the films. And maybe they didn't know exactly what they were looking for. And obviously, scheduled, to your burnout comment, people's schedules are busy and they're trying to get through things quickly. And so it's not necessarily negligence or oversight. It's just part of the system. So I think having a really solid specialist, and I'm partial to DOs in general because I was raised by one in Bob Adams, is that I think having a specialist involved is real critical to that development.
And along with that, other thing is, if you look at the report, sometimes patients freak out because there's like something horribly wrong at every level. And then if you really look at it, these are just kind of mild degenerative changes that they're describing in a paragraph format. And so it puts a lot of anxiety in patients. So I completely agree. I think having a specialist who looks at this and looks at it in detail with the patient, I think is really, really important.
Yeah, and I think that's many times the PT, when there's not that specialist involved, the next visit post MRI report is basically talking them off the ledge of like what's going on there.
Yeah.
Let's see. TJ has a question. This is great when there's this much interaction. This is the most questions we've ever had at one. Is this a procedure that would be beneficial at other levels of the spine or just the lower lumbar spine?
It is only approved for the lower lumbar spine. And part of it is the safety, because there's no spinal cord generally between L1, below L1 and L2. But when the company had to get this FDA approval, it's like Voltaren gel, right? Mm-hmm. Although it could work at every joint, it should work the same way. But when they had to get indications to get the medication approved, they had to get the knees. Same thing with hyaluronic acid. And so when the company had to get FDA approval, they went after the most common levels that's treated. And if you look at the data, vast majority of them were at L5S1, L4-5, or L4-5 and L5S1. So if you look at those numbers, they went after the indication. So unfortunately, yes, you can do it at the L2-3 level and higher up, but it would not be covered by insurance.
That's just from our standpoint too. I think of the lower back injuries, I think L3 below is 95% of them. It's the majority. Anybody sitting in a chair right now, which is most of us, that's where you're getting the stress. Last question here, and we'll wrap up. Eric has a question that says, can existing MRIs be used to analyze this for viability, or does this procedure need a new MRI?
It depends on how old it is, but yes, we could use whatever MRI. So even if you had it done 2 years ago, oftentimes we could first look at that first to see if they have M-plate changes. Oftentimes, if it's been several years old, I'd like to get an updated MRI to see if there's been changes. And also sometimes there's some evidence that some patients do have discitis from infection, for instance. So I would want to see if there's a progression of it. So if they develop like an abscess, like obviously we're not going to be sticking a needle in there. So yes. And so usually within a year is fairly safe, but if it's beyond that, sometimes we would get an updated MRI. And also to look for if there's changes. Sometimes they may have just one level. Now they may have 2 levels. So if while they're getting a procedure, we could do 2 levels at the same time if needed.
Well, I want to wrap up. I want to be respectful of your time and all the attendees. So I appreciate everybody coming. This was a really well attended webinar, and I appreciate all the feedback too. If for some reason you got here late and missed the first part, which it was there was good information there as well. This will be archived. You should get an email regarding how to find it. We'll also have it on our YouTube channel. Or if you just want to watch it again, you just like the soothing sounds of Dr. Lee's voice as you fall asleep, then it's a good catch there. I wanted to give a quick shout out. Another DO, Dr. Lauren Vernice from Swedish Sport and Spine, will actually be here later in the month talking about SI joints. So we actually kind of touched on that. So it was a great segue, not intentional by any means, but she'll be coming in to talk a little about SI joint. And so many people are out skiing and snowboarding and sustaining injuries that way, as well as just chronic sitting, which we all have a tendency to be doing a little bit more during the pandemic. I will, again, as I mentioned before in the show notes, have Dr. Lee's contact information on where you can find him on the website. And just really appreciate you taking the time. This is was great information. And I think each one of these we've had, I keep learning lots of great information, new stuff. And it's kind of really helped supplant the CEU courses that we're used to getting in person that we don't currently have live, hopefully maybe in the fall. But is there anything else you have that for folks that have questions or anything?
Yeah, and if you wanted to email me, you certainly can, about questions about the procedure. And then I thank all of you who treat back pain or suffering from back pain. Hang in there, and maybe this treatment hopefully can help a lot of people. And so if you look at the data, maybe 30 million people have chronic low back pain in the US right now. And this procedure really is targeting potentially 4 or 5 million. And so it's not for everybody. I just want them to understand that. I don't want you to think, oh, I have, anybody with back pain could get this. No, it's a very specific criteria. It's not for everybody, but for those patients who do have it, hopefully we could provide significant benefit for them.
Great. And what is the best email to reach you at, so I don't give out your personal email?
Yes. Oh, yes. That's a good question. And I usually don't get, but if you're like a physical therapist looking for, I would probably just have them contact through my Evergreen email, which is yjlee@evergreenhealth.org.
Okay. And we'll put that in the notes too for the therapists out there too. Great. I think we had about 10 countries represented here and quite a few different states. So getting some good reach for you. So hopefully there's some colleagues from around the country will see that too. Thanks again for coming. I hope everybody has a good rest of the week, and we'll have some information out about the next webinar, but hope to have you back again. This was super solid. Appreciate it.
We'll be happy to.
Awesome. Have a great rest of the week. Take care.
Thank you. You too.
Thanks, everybody.
All right. Take care, everybody.